I'm Bob Say, the chair of the Cardiothoracic Ethics Forum, which is a joint effort of the Society of Thoracic Surgeons and the American Association for Thoracic Surgery. We design programs for our national cardiac surgery meetings every year that address problems in ethics that are particularly pertinent for surgeons. In recent years, there have been a couple of trends that are both positive and, well, perhaps a little bit scary. The positive trend has been toward simpler and simpler methods of treating many surgical problems, for example, congenital heart disease, by the use of catheters and much lesser interventions than open heart surgery. This has resulted in good outcomes for a large number of people in many surgical specialties, with much less pain and suffering, as it were, than in the past. One of the scary things that's been happening is the move toward public reporting of surgical outcomes. So surgeons are particularly anxious to have the best possible results from their procedures. So the question has been raised more and more frequently as it becomes more difficult to train cardiothoracic residents. What is the obligation of faculty members to allow residents to operate on their patients in order to satisfy American Board of Thoracic Surgery requirements? One of the difficult areas for satisfying those requirements is congenital heart disease. For today's discussion, we have two pediatric cardiac surgeons, Dr. Rick Oye and Jim Jaggers, from the University of Michigan and the University of Colorado, respectively, to discuss the problem of training residents in congenital heart surgery. The discussion, or debate as it were, is based on a case that involves the chief of cardiothoracic surgery of a program that has a moderately active congenital heart surgery program, and there are two congenital heart surgeons, both of whom feel very strongly that they need to have the best possible outcomes for their patients, both in the interest of their patients and in the interest of the public reporting that's coming up down the line. And therefore, they don't allow the residents to serve as operating surgeon in any or most very few of their cases. Also, there are progressively fewer cases in congenital heart surgery that are not being, the simple cases that we used to train cardiothoracic residents in, that now are being done by interventional cardiologists rather than surgeons who are learning how to do operations on children. So the case is one in which the chief of cardiothoracic surgery is wondering to what extent he can require, or he should require, his faculty to allow residents to do surgery on their own patients despite their inclination not to do so. Because several of his own residents are facing the difficulty of not having sufficient congenital heart cases to report to the American Board of Thoracic Surgery when their training is finished. So to start the discussion, I'd like to ask Rick Oye to give his point of view on the question of whether or to what extent faculty members should be required to allow residents to operate on their patients.
Thanks, but you know, for the purpose of the debate, I'm supposed to be the pro person supporting that you can, or we're obligated or can be mandated to do this. And I think there's a lot of room for agreement, even though this is a debate. I don't think either of us would disagree that it is part of what we do. When we take on the mantle of an academic surgeon, we take care of our patients, we do research, and we educate the next generation. So I don't think that really we're going to disagree on that, but the devil's in the details and how you do it. And to address some of the things that you talked about, Yes, I agree. There are fewer of the most straightforward cases, whether they're ductuses or ASDs and things like that, that our interventional colleagues are taking care of now. But there are still plenty of cases, in my opinion, that our residents are capable of doing. They are very well trained. You know, they have incredible pedigree from college on through medical school. They're board. Many of them are board certified or board eligible general surgeons. They've done part of their heart surgery training already, and they're quite capable, and I think in many cases more capable than we give them credit for. They are, on the adult side, they're doing mitral valves, they're doing aortic valves, and it might not be appropriate to have them do a neonatal Roscono, but certainly they can do plenty of the older kids with aortic valve disease or mitral valve disease or tricuspid valve, pulmonary valve replacements and the like. So I think there still is a rich portfolio of cases to choose from to get them through. I think the other issues are whether or not it affects your outcomes, and I think the data are mixed if you look in the literature. But we've been a center that has traditionally allowed our residents to operate quite a bit, and we've done very, very well if you benchmark us against the STS, so I think it can be done safely. And I think that there's a bit of a parallel with clinical research. You still have to do many of the things that are important in clinical research, respect for the patient, beneficence, distributive justice, and those sort of things, I think have a bit of a parallel in medical education. And the sort of the final question is whether a chief can mandate. In a way, a chief can do whatever he wants, I suppose. I know in our program, actually part of our salary is at risk, and it's not an insignificant amount of our salary that's at risk for a number of different things that we should be doing anyway. It may be getting your paperwork done on time, but it's also teaching that you have to show that you're doing a certain number of the cases with the residents or allowing them to do a certain percentage of the cases.
I don't think you're going to find a lot of disagreement between Rick's and my commitment to training residents. I mean, we've benefited from that, and we both have training programs and we train residents. I guess the question comes down to, though, is can you be sort of encouraged by your division chief to do this when you may or may not feel like it's the best thing for your patient? There are fewer cases. I mean, I looked back just recently to see this in preparation for this debate, and we're doing roughly half the number of those easy cases that you might consider a resident case than we were even 5 years ago. So there are fewer, which means if you have, depending on the number of residents you have, distributing those across all those residents can be a little bit challenging. But to me, it's almost irrelevant. I mean, you could say the same thing about mitral valve surgeries, esophageal surgery. There's residents all across the country that aren't getting enough of their cases because of this very problem. Your mitral valve surgeon is very successful in more of a private practice model, and he's not willing to give up cases. You don't have enough esophageal cases because the general surgeons do the esophageal cases. So it gets down to the point of, if you really feel like your primary responsibility is to your patient, and you feel that you can't provide the best optimal outcome for your patient, then you're sort of ethically bound to not help the resident do the surgery and to do it yourself, regardless of what your division chief is. And if your division chief sort of says, you got to do this, part of your salary's tied to this, that raises a little bit of a different ethical issue. I mean, that's a bit of coercion, and is that the right thing to do? So there's multiple layers to this debate, and I think tomorrow we'll probably be able to get into some of those things. But
well, Jim, do you think that the directors of cardiothoracic surgery are not coercive? I mean, they don't do anything to get their faculty to do the stuff they need to do?
Of course not. I mean, there's sticks and carrots for everything we do, and the ethics of this is a balance. And so, but in this particular scenario, in which your pediatric heart surgeons, even though there's a requirement and you're employed by that training program, if you really feel, if you're taking the ethical tact of non-maleficence and trying to look at the best outcome for your patient, you got to square that against your training program and your professional responsibilities, and so obviously that's why we're debating this. Now you can argue all day long about whether a thoracic surgery resident needs to be the primary surgeon on 10 cases. Is that really in the best interest of the trainee, and does it really train him to do what he's ultimately going to do, which is adult cardiac or adult thoracic surgery? But that aside, I mean, if the requirements are there, then they have to get them somehow. Now there is a mechanism in the board to deal with this. You can petition the board, and the board can say, our guy didn't get enough cases, so can we get him through this? And oftentimes they will, but that's not what you'd want to do every year, probably.
I think it's a very good question. Are the board requirements appropriate at this point? And that's obviously a whole other debate, but I think that's something that I was thinking about also. But I think what you were talking about mandating, I think it depends on the case. That your chief isn't going to mandate you have them do that particular case. It's that a reasonable amount of cases, a reasonable percentage of the cases, and they are there. So I think that's just a little bit of a difference in looking at it, whether you look at it at the individual cases. You mandating that I do have that resident do this particular case, which isn't really what it is. It's that you have to do a certain, in our practice, a certain percentage, and the numbers are a number, but it's really a bit more about, more about good faith and your intentions to get cases. And no, I'm not mandated to take them through, a first-year cardiothoracic resident through a Norwood. But I think it's not an unreasonable expectation of our position as academic surgeons.
Jim mentioned in his introductory remarks that there, just in the past 5 years, there have been noticeably fewer cases of the simple variety that we used to train cardiothoracic residents with that are available anymore because they're being done by the interventional cardiologist or interventional radiologist. So continuing that trend, and not talking about today, but talking about a few years from now, this problem is not going to get any better. If anything, it's going to get worse, and maybe significantly worse. So surgeons are going to be faced with the problem of their own confidence in their ability to get a good result, perhaps even the best result, by helping a resident to do the case rather than doing it themselves and having the resident watch or assist. Is that a reasonable? But there are going to be some surgeons who say, that's just not right. I'm just not going to do that. I don't trust that I personally am capable of taking a resident through a more complex case and coming through it with a really good result. So how are you going to deal with that? And assuming that the board is hard-nosed and by God you have to do these cases, and that's not so far-fetched either. But assuming that the requirements continue, how are you going to deal with that?
I think coming from the other direction for the debate, when I looked at the sort of very similar thing, looked at the types of cases that we're doing, and instead of maybe looking for those, how many ASDs have disappeared, I looked at the whole sort of population of cases that we've been doing and started looking at the cases, well, which ones would be appropriate, which ones wouldn't be appropriate. And yes, they're not ASDs, but there are still, as I said, plenty of cases that I think would be appropriate. And it is a little bit of an ethical dilemma. There is no doubt that either of us can do it, frankly, better, faster, shorter bypass times, shorter circuit arrest times, or whatever you want to use as your metric, than the fellow. And that there is an ethical dilemma there. But again, to me, the parallel is clinical research, where the society benefits and the individual may or may not benefit from the operation or the research intervention. So I think if you look at it sort of flip it on its head instead of just say, well, look, our ASDs have cut in half, and look at the big body of cases. There's still plenty of cases, and frankly, a lot of them are going to come back. All those melodies that are going in now in patients, they're not going to last forever, and maybe they can put a second one in, but a lot of those will be back. Those will come to roost.
I mean, I think you're right. I mean, because what traditionally was a case for a resident is morphing and changing now. So that as the adult congenital population grows, those patients are going to become more available for the residents for trainee. But what you were saying was essentially argues for the congenital training program, which is what we now have. So that now we can consolidate the training of congenital heart surgeons into different areas. And maybe that's the solution for this particular program director or this particular general pediatric heart surgeons, is you need to farm those pediatric surgery cases out, or take those residents out and put them in a different place where they can work with attending surgeons that are more comfortable and better able to train them. But you brought up a point about, the greater good, and because this is an ethics debate, we have to talk about that. But so much of Western medical ethics is gradually sort of morphed into that sort of consequentialist, utilitarian sort of thought that whatever we do should benefit the greater of society. But on the other hand, it gets back to that sort of individual relationship with that individual patient, and which one of those wins the battle, which one of those wins the day. The deontologic sort of look at things where you take care of that individual patient, that individual actor, or do you look at the greater good? And you can actually make an argument on both sides of that for both of these issues, and I'm sure that's what we'll get into with this debate some. So.
Okay, our time is nearly up. Any final comments or thoughts about this? One additional thought that I had was that we really haven't outlined the extent of the problem, because more and more we're training cardiothoracic surgeons, not people who have finished their general surgery training and now in their 7th and 8th year of training and very experienced, but in I-6 programs, in integrated 6-year programs where the residents that we're training are less experienced than the ones that we've been used to in the past, and that complicates the problem even further.
Hopefully they're maybe younger by a year or two, but have had more cardiac exposure. If you think about the average general surgery person that comes through anymore, many of them have never seen the living human heart, and I think that they're challenging, very challenging to train. I mean, we as general surgery residents, I'm sure you did bypasses, you put people on pump, you did sternotomies, and literally I've had applicants from general surgery who have never seen the living human heart. So I'm hoping actually that the I-6s maybe are a little bit better prepared, but
we can hope.
We shall see.
Okay, Rick and Jim, thank you very much, and we look forward to discussing this further tomorrow.
Thank you.
Thank you.